We're going to talk today a little bit about re-irradiation, some of the considerations and what parents and patients should be discussing as they're considering whether or not re-irradiation is a good choice for them. We're glad to be joined by Dr. Luke Pater, Associate Professor of Radiation Oncology at University of Cincinnati and Cincinnati Children's Hospitals. Welcome.
Thank you.
Obviously, this is geared more towards families and patients. And as we go through that, and as they start to face progression, whether it's through DIPG, DMG, or even medulloblastoma, they're getting recommendations to consider re-irradiation. Can you explain what this involves?
Sure. And thanks again for the invitation to take some time to speak with you today. So re-irradiation, in terms of what it involves, not surprisingly, it's very similar in many ways to what the patient and their family would have experienced the first time through with treatment. So while the considerations are different due to the prior exposure, many of the patient experiences, the family experiences are actually quite similar with the planning session, the mask making, the time for treatment planning, and then the daily radiation therapy treatments. The number of treatments can vary, and so depending on the time from the initial treatment, what other therapies are being administered, there's some things that go into duration of treatment, which could vary from what their first experience through was. But in a lot of ways, the process should look quite familiar.
Now, with that, obviously, a lot of these are being brought up fairly new. I mean, there's been kind of a new interest in this re-irradiation, and they're getting these new recommendations. Is this based on some sort of new efficacy findings or new studies that we've seen out there?
Sure. So I would say that re-irradiation in itself is not new, but I would definitely agree that we're using it more commonly than we used to. And that is due to some increase in the amount of experience as well as data that's out there. This is not unique to brain tumors. So re-irradiation for a variety of different tumor and disease sites is increasing in its use. A lot of that is due to data that shows its safety. And as we've grown our understanding about what certain tissues can tolerate, what a time lapse might do for that ability of that tissue to tolerate re-irradiation, we've become more comfortable for considering it, and also grown in our understanding about the safety and risks. So while the concept is not new, we're applying it a little more broadly than we used to, and that's due to more safety data than anything else that we can consider it, and we believe that it can be safely offered.
Okay, well, you talked a little bit about safety issues. Is there anything that specifically parents and patients should consider, and specifically to side effects though, and kind of those safety considerations?
So safety discussions are fairly similar to the first time through, with the main distinction being that the brain does not forget the initial exposure to radiation. And as a result, while a lot of the specific side effects and risks are similar, because we're typically treating a similar region of the brain, the risk of those side effects typically increases with a second course of radiation. And so much of the discussion will again sound familiar. Some tumors may have migrated to other regions of the brain, and that can change the discussion slightly. But in a lot of ways, the risks are similar. It's just that the percentage likelihood of those risks may increase with a second course of radiation. And so depending on what side of the brain you're talking about, if it's close to areas in charge of vision, in charge of movement or sensation, those risks will be very similar to the first course through.
Are a lot of times are those immediate, or are those usually more long-term type of risks?
Still more long-term in general. Most of the risks of radiation in the short term is felt due to swelling, inflammation, and that can be something that you see in the days, weeks, and months kind of a time frame and managed as such. But more of the higher risk side effects and toxicities are related likely to changes in blood flow or changes in blood vessels, scar tissue formation, things that actually happen over months to even years. So many of the more concerning risks still remain somewhat delayed.
Of the different types of radiation that you go through, is one better for re-irradiation than another? Are there certain types that they should be considering depending upon each type of tumor or how they're approaching it?
Sure, and That's a complicated question because there are so many factors that go into that decision. Radiation, much like the first time through, is almost always externally delivered with brain tumors. So similar to first time through, a machine moving around the patient, aiming the radiation in. The type of radiation that we usually have a conversation about is a discussion about photon radiation and proton radiation. And the benefits of one over the other vary a lot of times depending on a variety of different factors. Again, kind of how long it's been from the upfront treatment, what the patient's current clinical condition is, also what was the dose given to certain structures in the brain last time, and what might the dose be with a second course of radiation. That can guide you towards one type of either proton or photon treatment being either more or less beneficial depending on the situation. And then, obviously, it comes down sometimes to just socioeconomic situations where if you say that proton treatment is potentially more safe for the second course to decrease some risk to critical structures, a patient may not be able to make that happen due to their situation, again, either financially, family surroundings, et cetera. So it's a complicated decision. Sometimes photons are right, sometimes protons are correct, and many factors go into that.
Specific to medulloblastoma, DIPG, DMG, is photon considered for re-irradiation? Because I know in a lot of cases it's usually not part of the initial radiation.
I've used, and most people use both photons and protons in the upfront and in the re-irradiation setting, depending on the clinical scenario. The reason that protons are sometimes considered second time through is due to that decreased exposure to surrounding tissue. For example, if you're close by the optic nerves, they may have seen their known tolerance dose, meaning their known dose below which risks are quite low and above which the risks quickly escalate. They may have seen that through their first course of radiation and may not tolerate much, if any, further exposure. And so even if the tumor is not involving them, if it's close by, you may need proton radiation or at least a photon plan that significantly decreases the exposure to those structures compared to the first time through. And so the decision's complicated. It goes into a lot of things related to what happened the first time through and making a decision about what's best the second course.
And certainly by patient, excuse me, by patient as well, I'd imagine.
Patient and clinical scenarios, how they're doing at that time, and what other therapies they might receive.
Okay, other therapies. Is usually re-irradiation suggested as part of a combinational therapy, or is it typically provided alone?
Commonly given with other therapies. It certainly depends. Each tumor type is different because each chemotherapy or targeted therapy or immunotherapy varies depending on which brain tumor we're talking about. But many times re-irradiation is considered within either the context of a clinical trial or within the context of other therapies. They may augment radiation's effect. They may increase toxicity. So there are some circumstances where a patient may be receiving an agent that needs to be held, or they may need a small break after radiation is completed before they start that therapy. But it's frequently given either with, alongside another agent, or soon after another agent's been delivered.
Okay. Is there anything else that you can tell us about re-irradiation that parents or patients should consider?
Sure. I guess I'd also mention that we recognize when we see a patient for re-irradiation, it's re-irradiation for a reason. And we know that the patient has been through a treatment course before. They may have seen other therapies since we saw them last. I always say it's kind of a joke that patients give us when they see us for their last treatment. I hope I never see you again. And we understand that, and no one's offended by that. We know that no one wants to have to go through a second course of radiation. But with that being said, we do feel there's a growing data set that shows us that it's a safe option and one that can improve frequently quality of life for our patients when delivered. So we're happy to deliver it, even though we all recognize that no one wants to go through a second course.
Fantastic. Well, thank you. I appreciate you joining us. As we said before, this is Dr. Luke Pater, Associate Professor of Radiation Oncology at University of Cincinnati and also at Cincinnati Children's Hospital. We're glad you could join us and help clear up some questions on re-irradiation.
Thank you for the opportunity.
Thank you.
Bye-bye.